Hello everyone, greetings. My name is Anne and I'm the IWMF's Wellness Program Coordinator, and I'm really excited to welcome you to today's Waldenstrom's Wellness Webinar, where we'll be learning about coping with fatigue and sleep disturbance, since they go hand in hand with the cancer diagnosis, as I've come to learn. These topics of fatigue and sleep are topics that come up all the time, very frequently in the world of Waldenstrom's. We'll also be doing a very short movement practice to alleviate fatigue. I will share that with you. And then we'll be asking our esteemed guests all of our fatigue and sleep questions. Before I introduce our guests today, I just want to say a quick thank you to our wonderful IWMF home office staff, who are here to help us both manage the room and soak up some of our guests' wisdom. So just a reminder, please stay muted unless we invite you to unmute during the question and answer period, since we're recording. And we'll invite you to type your questions into the chat when it comes time for that. And I'll do my best to funnel them to our presenters during that question and answer period. So I'd like to also just say a quick disclaimer about the wellness programming that we are offering you, that it's all complementary and integrative. These practices are used to be in conjunction with standard medical treatment, along with the approval of your doctor. So let's get rolling. I'm really thrilled to introduce two amazing women who are both clinical psychologists and who are both doing the really important work of studying ways to help those affected by cancer improve their quality of life, especially as it pertains to fatigue and sleep issues. So you may be familiar with Dr. Rina Fox. She's presented for the IWMF before, and she has participated in dozens of published research studies. But I'm wondering, Dr. Fox, if you could just tell us in your own words, what work are you most passionate about doing lately? Putting you on
That
the
is a
spot.
great question. Thank you, Anne, and thank you for that lovely introduction. And I will give a disclaimer that I am on the tail end of a real whopping case of laryngitis. So I apologize for the weakness of my voice. And Dr. Muench has very generously offered to jump in should it really give out. So I did want to put that disclaimer out there. I do not normally sound like this. In terms of the work that I'm most passionate about, my research program has two real main areas of focus, one of which is sleep disturbance. You'll hear us talk about this a little bit later, but as you mentioned, fatigue and sleep disturbance and cancer really often go hand in hand. And unlike some of the other symptoms that individuals affected by cancer experience, they don't often skedaddle when treatment is complete, but rather they can stick around for a really long time. And I think there's a kind of challenge that occurs where either people don't understand or recognize that this is a problem, people being both patients and providers, or it just doesn't feel like the most important problem in front of you at any given moment. And I think that sometimes is true, but part of the work that I'm doing is really trying to elevate the attention that is placed on these symptoms and these concerns from everybody's perspective, because I think we all know a good night's sleep can really have a extremely positive domino effect on everything else that might be happening. So this really is a main focus of the work that I'm doing.
Thank you so much for sharing that. And we're so lucky to have you here today. And I'm sorry about your laryngitis. Thank you for pushing through. I think it's when I hear the word fatigue, I have my own sort of knowledge of that as just a human being. But fatigue as it relates to cancer can be really different. And I'm excited to learn about that, especially because fatigue was actually the symptom that got my father's Waldenstrom's diagnosed. And even though he was 80, he said, "This is not normal for me. This is not normal fatigue." And that was what eventually led to him asking his doctor to do blood tests. And we're very lucky to be in the Penn Medicine system. And our second guest is actually in the Penn Medicine system as well, Dr. Alexandria Muench. She goes by Lexi. She is a research associate there, and she's in the behavioral sleep medicine program, where she studies ways to treat insomnia and fatigue. And I'm curious, Lexi, if you would share maybe a little tidbit about yourself. Why did you say yes to today's presentation?
Yeah, so I guess like Rina said it best, this area of work, fatigue and sleep in cancer, is what I'm most passionate about. I often say sleep, eat, and breathe it, and advocacy around it. So when Rina approached me, I was excited. I love to do patient-facing talks and education around this issue, because like what was said previously, I think it often gets pushed to the bottom of the totem pole because, right, there's other priorities and things like that. But I often think about thriving, right, not just surviving. So quality of life and what is it like to live with fatigue and sleep disturbance all the time. Oftentimes patients will say not great. And speaking to what you said about your father, that's also a common thing, that paying attention to these things, if you're sleep deprived, if you have a sudden bout of insomnia or more so fatigue, that's our body often telling us something. So my work really focuses on that piece. I have a clinic dedicated to treating sleep disorders and fatigue and cancer, but also on the research side, developing targeted treatments for these things, because that's the other piece. We don't really have evidence-based treatments right now that work effectively to manage fatigue specifically in cancer. So my area of focus is really that, identifying what can be done to treat this issue.
Got it. Thank you so much, Lexi. I appreciate that. So I will just let you guys take it away from here, and we'll see you in a little while.
All right, so I'm going to share my screen. Our first part of the presentation is specifically on cancer-related fatigue. And I'll be giving that part of the presentation, and then we'll switch over to Dr. Fox for the sleep portion. So what is fatigue? Do you want to, next slide? So according to the dictionary, the definition from Merriam-Webster is a weariness or exhaustion from labor, exertion, or stress. But now we want to ask you, what does cancer-related fatigue mean to you? So if you wouldn't mind going to www.slido.com and entering this code, we'd love to know from you, what does cancer-related fatigue mean?
And I'm going to give it a minute, and then I will pull up the answers. So you'll be able to see your responses live, but I don't want to take this away until you've had a chance to go to the site. If you'd prefer to do this on your phone, if you have one, you can just hold it up to the screen, and that QR code will also take you directly to the poll. Okay, and I see Anne put the information in the chat. There we go. Starting to come in.
We've got tired, debilitating, no energy, exhaustion, abnormal tiredness. Ooh, exhaustion seems to be a big one. Undue exhaustion, crushing exhaustion. Sleeping 12 hours a day, debilitating. Deep bone fatigue, depressed. So as these come in, we can talk through some of them. And as you'll see, the exhaustion seems to be one that everybody's saying. And what we're seeing here is no energy, hard to be active, depression, never ending. And we're going to talk through some of these as we progress through our conversation today. But all of these things, no energy but easily tired, can really impact your quality of life. Unable to do dishes, so not able to do the things you used to do. A loss of maybe joy, not that dishes bring joy, but other things that maybe used to do. Feeling older than my age, So I think what we're seeing here is really an overall loss, like I said, of quality of life. All right. So what about cancer-related fatigue? So some of these things came up right when we just did the Slido, but the definition from the NCCN, the National Comprehensive Cancer Network, is cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion, related to cancer treatment that is not proportional to recent activity and interferes with usual functioning. And so let's break that down. So cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion related to cancer treatment that is not proportional to recent activity and interferes with usual functioning. So it's distressing and persistent. It doesn't go away. It has aspects of physical, emotional, and or cognitive tiredness. So it's really hitting kind of what we say, a biopsychosocial approach, right? So it's hitting you physically, emotionally, cognitively, and you feel exhausted. And we saw that in the Slido. And it's not proportional to recent activity, right? So it's not like you had a really active day and it's understandable that you might feel fatigued or tired. And it interferes with usual functioning. So we saw on the Slido doing things like the dishes, playing with your kids, basic life things that you have to get done. It's really getting in the way of your quality of life. So fatigue and cancer-related fatigue are different beasts, right? Like what we see here. And so cancer-related fatigue is often more severe, more upsetting, more disabling, more long-lasting, and more difficult to relieve, as I alluded to in my introduction. We really don't have effective treatments for it at this time, which makes it quite distressing because it often feels like there's not much you can do about it. So how is cancer-related fatigue experienced? So there's meta-ethnography of 16 qualitative studies with 6 overarching themes. And what they found over these studies was a loss of self, embodied, sorry, I was going to go through, but we can move to the next.
No.
And we're going to go through each of these: embodied experience, role changing, misrecognition, small horizon. We're going to go through these slide by slide. So embodied experience, so physical symptoms like heavy limbs, legs like jelly or wobbly legs, and the body just feeling worn out. I often say to patients, like, if I were to put a bed here in the office, do you feel like you have the flu, or is it more of a sleepiness experience? And fatigue is more feeling like you just have the flu, a lack of energy. Next slide. Misrecognition. So a lack of recognition of cancer-related fatigue by survivors, relatives, and health providers, right? And so there's this idea, because I look so much better than when I was having treatment, people think that I'm back to my prior fitness, or my family can easily forget how tired I can get, as this is not obvious. So because you can't see it on the outside, there's a lack of what you're experiencing on the inside. Next slide. Small horizon. So reduced freedom, narrowed functioning, like we had alluded to before, feeling like you're drowning, gradual submersion. You can't do the things that you used to do. And there's a loss of sense of hope and values and that type of thing. Role changing. So with this, right, with a diagnosis of cancer and into survivorship, that can often feel like roles are changing. And then you add this cancer-related fatigue onto it. So you're really trying to adapt and adopt other life roles. So for example, you were used to running things at first, and it's some kind of contradiction. Oh, sorry, we had a check them up. It's a shock. You manage everything, and then you suddenly feel limited. Even your young child is bringing you a glass of water. I had a patient once who said that she was having a hard time. Her role with her partner was she did a lot of the laundry, and she couldn't carry the laundry up the stairs anymore. And while she didn't exactly, love doing laundry, she really was noticeable for her that her roles had changed in the household. Next slide. And a loss of self, an impact on identity. So for example, I feel like I'm in the body of an 80-year-old, and we saw that in the Slido, right? That theoretically I know what my capabilities are, but in reality, things have changed. It's different. It's two different things. You know what you can do, but on the other hand, you don't, because again, your roles have changed and you've lost a sense of self. Next slide. So regaining one's footing, struggle, adaptation, and acceptance. If I'm more tired, it's not the end of the world, so I'll rest and do less. It's not the end of the world, and it's possible to live at a slower pace than I was used to doing. And also it's all about attitude, really. It's altering what you can accept, what you can, and accepting what you can't. So that's really, you know, I have CRF, but I'm not defined by this situation. So how common is CRF? Short answer, very common. The literature says about 52% of patients. This is across 84 studies, but anecdotally, and in other studies, it might be even more. It is the most common side effect of cancer treatment. It can also be a symptom of cancer itself, and it's often rated as the most distressing. So again, how common with severity? What we see here on the left in the severity graph is 23% would rate it as moderate, 18% is mild, 15% is severe. By sex, we see that females experience it a little bit more, about 39% of the time, with males experiencing it about 34%. By age, less than 65 years, about 42% will report CRF. Over 65, about 46%, and by treatment, if you just receive surgery, about 19%, but when you combine chemo and radiation there, about 34%. Sorry, cancer-related fatigue. Sorry, I've been abbreviating it. Why does cancer-related fatigue happen? Bottom line, we don't really know. That's part of my research. Why is this happening? Where is it coming from? Why does it persist is a big question. But some things that may contribute, systemic inflammation. So cancer treatments like radiation and chemo can cause inflammation throughout the body, anemia, depression, sleep disturbance, although there has been some literature to suggest that sleep disturbance and cancer-related fatigue are separate. More recent literature is suggesting that they might actually be interrelated. Physical inactivity, higher body mass index, pain, infection, difficulty breathing, problems with organs, coping strategies and expectations, right? The mental load in general of having cancer and wanting to do the things that you used to do can be distressing and lead to fatigue. And cancer treatments, as I've said before, can definitely impact how much fatigue you have and how long it persists. Okay, so when does CRF happen? This is the ultimate question, right? Does diagnosis, treatment, remission, we think it kind of, it can come about a diagnosis and changes throughout. Next slide. And how long does CRF, cancer-related fatigue, last, right? That's another question that we're trying to answer. So this shows the percent of patients who ranked each symptom as lasting the longest. And what we see here, not surprisingly, is fatigue is the unfortunate winner, with nausea coming in second, depression coming in third, and pain last. But fatigue is really one, especially depending on the type of cancer you have, that can persist the longest, well into survivorship. And what impact does cancer-related fatigue have? So this is the percent of patients who said the symptom impacts everyday life the most. And what we see here is that 60% of people said that fatigue has the most impact on their daily lives, with nausea coming in second. So what can we do about cancer-related fatigue? So the NCCN guidelines for patients and survivors should care for cancer-related fatigue have said that strategies to manage fatigue include treating the causes, education and counseling. So this is a big one. I think preparing your patients that this might be a symptom is helpful. Physical activity, exercise has been researched a bunch and seems to be helpful. Cognitive behavioral therapy, a psychological intervention. Mindfulness-based stress reduction is a good one. Supportive expressive therapies, psychoeducational therapy. Again, I think education is very empowering around this. Nutrition counseling, what you eat can help and how and when you eat it. CBT for insomnia, excuse me, which Dr. Fox is going to talk about soon. Acupuncture and psychostimulants, although the literature on that is mixed and they're not always the best, but they can be mildly helpful. So I got ahead of myself and talked through this, so we'll move on to this next slide. So patient, family, education, and counseling. So education about fatigue, especially undergoing fatigue-inducing treatments. So radiation and chemotherapy have been shown, as I said earlier, to increase fatigue, especially depending on your diagnosis and your course of treatment. So understanding that this might be a symptom can be helpful. And that fatigue is not necessarily a sign that treatment is not working or that disease is progressing, right? It's a side effect of the treatment you're receiving. And fatigue can be a consequence of treatment. And also, we can always benefit from nutrition consult with a registered dietitian to make sure that you're eating the right kinds of foods during, before, during, and after treatment. Definitely talk to your doctor. General strategies. So energy conservation is a big one. So planning your days, making sure that you're not getting into the cycle of doing too much one day and then you're really fatigued the next day. So setting SMART goals around that, right? Maintaining a diary. So it's helpful. We do this a lot in fatigue and also in pain. Maintaining a diary where you can track your activity to see what activities might be causing more fatigue. Distraction, mindfulness, right? So not necessarily distraction like avoidance, but distraction, engaging in other activities that might help take your mind off the fatigue. And daytime naps, so less than 30 minutes in bed before 3 p.m. Preferably these things with an alarm can help to manage the fatigue a bit and conserve some energy. And my favorite thing that I learned recently is the nappuccino. So if you drink just a normal cup of coffee before you lay down for your nap, it helps because once you're waking up from your 30-minute nap, the caffeine is in your bloodstream and helping keeping you more alert and feeling better. So definitely recommend the nappuccino. So pharmacologic intervention, so I alluded to this earlier. So there's some evidence that psychostimulants and corticosteroids can help. Always consult your physician. What I'll say is a psychostimulant is usually prescribed as modafinil. The effects are mixed. It definitely can take the edge off a bit though. So consult your physician if this is something you're interested in pursuing. So non-pharmacologic interventions, physical activity. And when I say physical activity, not necessarily like running 5 miles, although if you do that, that's a beautiful thing, but light stretching, getting out, if the weather permits. Bright light therapy is number 3, but I'll throw it up here because getting natural sunlight can definitely be helpful. Even like sometimes with my patients who are limited in their ability to walk far or move, I'll say even walking to the mailbox, getting outside can be helpful. Psychosocial interventions. So things like cognitive behavioral therapy for insomnia, cognitive behavioral therapy in general, working out some of those thoughts around your fatigue and the distress related to it, and bright light therapy, right? If you can't necessarily go out and get natural light, bright light therapy, sitting in front of a light box, which can be prescribed by your physician for maybe like a few minutes a day can be helpful. So speaking more to physical activity, there were 72 studies, 5,367 patients in active treatment or follow-up. They found a moderate effect of exercise in reducing cancer-related fatigue compared to the control group. Exercise type does not matter. And as I said a minute ago, tailored to you. And you also may benefit from physical therapy or other exercise programs, but always, again, check in with your doctor first to make sure it's right for you. It's a good program. So here are some examples of physical activity that have been found to be effective for cancer-related fatigue. So supervised training, multidisciplinary sessions incorporating self-paced exercise. So pacing is important. Sometimes we have to learn that right when we're used to being super active. Yoga, I love yoga personally. I think it'd be super helpful. Cycling is really good. Aerobic exercise and unsupervised training, strength training, aerobic training, cardiovascular exercise, flexibility, right? It's always good to maintain flexibility. Walking, Tai Chi. So really low impact exercises can be helpful too, just to keep you moving, not put too much stress on your joints, right? But to minimize some of that cancer-related fatigue. So what if you're too tired to exercise? I hear this a lot, which is, so cognitive behavioral therapy, CBT in general. So CBT is really learning the links between thoughts, feelings, and behavior, providing education about fatigue, activity management. Again, I can't stress enough. A lot of the conversations I have with my patients are about pacing, right? It can be hard to slow down. Again, when you're used to pre-cancer and the fatigue, being super active, right? So learning to manage your activities in a way that is helpful to you, but keeps you moving. Coping techniques such as stress management, relaxation. All of us could stand to incorporate more relaxation and deep breathing into our day. Recent research has shown that CBT for insomnia and cancer helps patients with fatigue as well. We're doing some of this work. So CBT for insomnia, which Dr. Fox will get into later, is a little bit different than standard CBT, which is more focused on building those connections between thoughts, feelings, and behavior, but it's more focused on managing your insomnia. But we are finding in a study that we're doing at Penn that CBT for insomnia can be helpful for fatigue as well. So stay tuned for that. So what does CBT, cognitive behavioral therapy, look like? So 1 hour a week, usually, depending on your schedule, interactive sessions with a therapist. It is tailored to the patient. Usually an average of 12 sessions, give or take, on your needs. And techniques and interventions can look like challenging, unhelpful thoughts, such as I cannot do anything about it, I'm helpless, right? It's such a distressing feeling. Learning about coping skills, scheduling fixed sleep-wake times, activity management, and homework, right? So we're really trying to build and empower in this intervention, giving you things to take home so you can build those skills. So things that come up can be, I can't afford to see a clinician for psychosocial treatment. I don't have time. I don't have access to providers. I'm not interested in CBT. So bright light therapy, commonly used to treat seasonal affective disorder. Systematic exposure to bright light may normalize circadian rhythms. And let me X this out. Pilot studies show that it may treat fatigue in cancer patients and survivors. So bright light therapy is really promising for fatigue. There's more and more research coming out on this. I will add here, they're doing some really cool research, I think at Mount Sinai in New York, where they're changing the lighting on the cancer floors to mimic more daytime light and help, and it's showing to improve mood and fatigue. So bright light therapy is definitely helpful. So what does bright light therapy look like? So 30 minutes each morning upon awakening, 4 to 8 weeks. Bright light, it's a broad spectrum light. It's usually a small lamp positioned at a 45-degree angle about an arm's length away. And there's also light goggles. I went to a talk at Mount Sinai, and one of the speakers was handing these out. They're very cool. Again, the research on this is super promising and seems like it'll be accessible to more and more people, which is always what we want, right? Accessible treatments. So the bottom line, cancer-related fatigue is real and is different from regular fatigue, right? It's persistent. It can be quite severe and distressing. Common, severe, impactful, and long-lasting. Unfortunately, right now, the causes and mechanisms are unknown. However, there are a variety of tools available to treat or help with the management of CRF, like we said, exercise, excuse me, now I'm losing my voice, exercise, bright light therapy, if it's accessible to you, cognitive behavioral therapy, both in general and for insomnia. But again, always consult your physician first to make sure that these treatments are the right fit for you. All right, and now we're going to do some movement with Anne.
Yeah, I think maybe before we pop into that, I'd love to ask some questions. We had some questions coming up into the chat specifically relating to fatigue. So before we move on to that, maybe we could get a couple of these questions answered. So I think everybody here is probably wondering, does all this apply to me because I have Waldenstrom's, which is a type of blood cancer? So would you say that the studies that you guys have been, looking at and participating in, do they involve patients with blood cancer? So is CRF, cancer-related fatigue, something that would apply to people with blood cancer or WM patients?
Yeah, for sure, for sure. I think, a lot of the fatigue literature that we have so far, a lot of times the patients are more with breast. However, I think that cancer-related fatigue in these treatments definitely could help across the cancer spectrum. Again, we don't know quite the mechanisms yet. And if they differ by type of cancer. We do know that different types of cancer have different severities of cancer-related fatigue. However, I think these treatments could, at this point, be applied. And certainly our goal is to do more research across the spectrum of cancers. So stay tuned for that. But I do think these treatments could be applied, and this information can be applied across different cancers.
Yeah, and I'll jump in and say, as Dr. Muench said, as is often the case, much of what we know comes from research that was done with people who have had breast cancer. That's frequently what happens in the scientific literature, but there are studies that have been done with patients, like a mixed cancer sample. So any type of diagnosis is eligible to enroll in the study, and that includes hematologic malignancies. And those studies have also found a lot of the same things as they relate to cancer-related fatigue. So I'm not aware off the top of my head of anything that's been done specifically with Waldenstrom's, and being honest, I'd be surprised if I found anything specific to Waldenstrom's. However, I don't think that means that these findings wouldn't apply to Waldenstrom's.
Yeah.
Got it. Thank you so much. I think another one that has also come up during some of our wellness classes, would you say that cancer-related fatigue, how does it differ from that you would experience due to depression or aging? Those are two pretty different things too, but anything you could speak to on this topic, how it differs from depression or aging fatigue?
Yeah, I think, that's a great question. I don't know if we know enough about fatigue at this point to say specifically like how it's different mechanistically, but what I will say is what we see in cancer is it's so persistent and so hard to treat. I do think, with depression, some of that fatigue will resolve as the depression goes away. So if they go through a course of medication or they receive CBT or cognitive behavioral therapy or both, the cancer-related fatigue, it doesn't seem to dissipate after treatment has finished. And that is what is so interesting about it and distressing about it, that many of the patients I see have been finished with treatment for years, but the fatigue remains. Now, some of that might be due to medications they're on, post-treatment. However, again, the fatigue seems to be much more severe and much more persistent than what we see with fatigue of age, potentially, and depression.
Rina, did you want to add anything to that, or?
Just what that made me think of also, one of the things that makes fatigue a little bit more difficult to understand is that there's no test, right? Like we can't give somebody a blood test and say, oh, your fatigue numbers are high. It doesn't exist. The only way fatigue can be measured is by what we call patient-reported outcomes, or basically somebody describing their experience to you. And people describe fatigue in really individualized ways, which is absolutely appropriate. But what that means is it's really hard to compare one person's description to another person's description and say, oh, this description is depression-related fatigue, or this one is cancer-related fatigue, or this one is aging-related fatigue, because there is no objective scale on which we can compare them all. So again, I don't think this is a problem. This isn't a negative. It just makes it a little bit more challenging to disentangle all of them. So we end up doing kind of what Dr. Muench was suggesting, where we look at these overarching patterns of, well, a lot of the time, people with a history of cancer describe fatigue in this way, whereas people who are aging but don't have a history of cancer describe it in this way, whereas people who have depression but don't have cancer, or maybe do have cancer, describe it in this way. So that's how we start to make those those take-home messages. But that's one of the reasons why it's so hard to figure out kind of what exactly fatigue is and why it's happening and how it presents for everybody, because measuring it is really challenging.
For sure. We had a lot of questions coming in about different drugs. Somebody asked what was the name of the drug that you were talking about related to alleviating fatigue. And then someone else asked about the drug Sunosi. And then we were talking about some supplements like pot gummies and other medications like Ambien, I think she means, ambiance, Benadryl. So they're kind of asking about what are some of the drugs that could be helpful here.
So I had mentioned, because there's more probably research on modafinil and cancer-related fatigue than most, modafinil, but again, what I'll say is the research it's pretty equivocal that it doesn't work that well for cancer-related fatigue. I think at best, it takes the edge off. And I think part of the problem with creating drugs to treat it is we don't really know what we're targeting. So, there's some recent thoughts that cancer-related fatigue is emanating from the brain, meaning that over time, when your immune system is working so hard and is overreactive, that we're kind of losing some of those things in the brain that would promote wakefulness. But that research is very new, so drugs just aren't there yet. In terms of some of the other medications that were mentioned, those are really drugs that promote sleepiness. And so those would be drugs that you would take to go to sleep and stay asleep. And so, I'm not a physician. I don't want to give medical advice. But what I will say is I wouldn't recommend taking those to manage fatigue per se. Those would be taken more, again, to help you sleep at night. But again, the drug I mentioned for cancer-related fatigue is modafinil. Definitely talk to your physician about it. It's a stimulant drug, psychostimulant. So yeah.
And modafinil is also known as Provigil.
Yeah.
Got you. Thank you so much for that. We'll just wrap this question portion up with talking about one of the contributing factors, anemia. This comes up a lot in our classes as well, like low hemoglobin count and anemia. And do you have thoughts on an iron diet? And that could segue into talking about, is there a specific fatigue reduction diet that you might, I know that sounds like another whole webinar, honestly, but, but maybe touching upon foods that could help.
Dr. Fox, do you want to take this one? I think my knowledge of the nutritional aspects of fatigue might be limited here. To you.
Sure. And I mean, I am not a registered dietitian, so my knowledge is also a little bit more limited. But what I will say, for something like anemia, I think of that a little bit differently than fatigue, because we actually do have a mechanism to target. We know that that's related to iron stores in your body and in your blood. So eating food that is high in iron and accessible iron, like greater red meat, for example, mechanistically can target that more directly. So there is more evidence behind that. Again, I would talk to your physician before making any changes to your diet. Make sure that it is appropriate for you and your own individual medical history. But that is something, because we understand the mechanism a little bit more, I do think that there's a little bit more evidence behind that. In terms of nutrition for fatigue specifically, I know there's some stuff out there. I am hesitant to really comment on much of it, again, because this is not my area of expertise. I do know that there are some general food as medicine programs that are a little bit more holistic. The one that comes to mind for me is Cook for Your Life, which I believe came out of Fred Hutch, though I could be mistaken, the Fred Hutch Cancer Center in Seattle. That is one that has a reasonably good amount of evidence behind it, and you can investigate it. I'm not extremely well familiar with it, but I do know that it exists. And it was developed, I believe, with the cancer population in mind.
Got it. We are definitely exploring finding experts to come talk about this topic of nutrition for this population. And I will say, just in my travels to find that person, I did come across a woman named Suzanne Zick at the University of Michigan who's doing a study right now. She's recruiting for a study right now that is a fatigue reduction diet for those with lymphoma. But it is specifically, it might weed out a lot of our Waldenstrom's folks because it's specifically for those with diffuse large B cell lymphoma. So that's, typically only about 10% of those with Waldenstrom's will also have that. But I can definitely follow up in our email if anybody is interested in looking at that as a possible way that you can be a part of a research study that could help manage fatigue through diet. I'll follow up with that. So I think that we'll go ahead and move into a movement portion if you guys are ready for that. Let's go ahead and just shake it off a little bit. I think Dr. Fox, you probably need about half an hour for your piece on sleep.
Perfect.
Yeah, so I'll just make this 5 minutes. We'll just do 5 minutes of movement. Getting started in just one moment. Okay. So thanks for letting me tag along to your presentation, friends. I am a yoga therapist and the wellness program coordinator here. And I love learning about what could help you and, reading all of the research that's out there. As these doctors have told us that physical activity is one of the most successful interventions for cancer-related fatigue. We just have to do it. And that's why I'm here. So let's just get started with some really simple movements. And you guys can keep typing your questions in, and we'll get to them at the very, very end if you have more questions about fatigue. So let's go ahead and take a moment to stretch a bit. I'm going to come and to sit in a way where I have room around me to move my arms. And I'm going to plant my feet on the earth. We're going to start seated, and then we'll move to a standing posture, which is an option. You could stay seated if you need to stay seated. So I'm just going to breathe in, lift my arms up as far as feels safe. Breathe out, arms flowing down. Inhaling, arms rise. Exhaling, arms coming down. And as we move through our movement practice, the breath is really the secret ingredient. As I learn in, yoga training, breathing in, breathing out. So prana is a word that we learn that describes both breath and vital life force. So adding breath to movement, maybe you have PT exercises that you do, you might add the breath to them. Let's do 2 more. And 1 more. So doing about 10 of these arm salutes to get the blood pumping and the lymph fluid moving. And then optionally coming to stand. And you could stay seated if you prefer to stay seated. But getting up and just right away, either seated or standing, you could walk in place. And I'm moving opposite arm, opposite leg, lifting my leg up as far as I can. And if I need to hold onto my chair for balance, I can do that. And I can also do this if I'm seated. I can walk in place, right? Or maybe I can move the lower part of my body a little bit in some way, right? And you do not have to participate in this if now is not the moment for you to move. I'm breathing. All right, and then I'm going to take a pause, take a breath. I might take a little bit of a wider stance if I'm standing, or I could just be watching and maybe do this later on my own. And I'm going to move in what's called a cross crawl pattern, right? So maybe it's an elbow towards the knee, or a hand towards the knee, opposite arm, opposite leg. Right? You could do this if you're seated. You could do this in bed, opposite arm, opposite leg. You've got it, Sarah, beautiful. So a lot of our classes will feature movements like this, and we do have a cardio flow class happening tomorrow at 2 p.m. if you're interested in keeping this movement practice going. All right, and then I'm taking a breath, taking a little break here, and bringing my arms down at my sides. And I'll just start by lifting my right arm up and over, and I'm going to let my left arm really relax here. So I'm stretching the side of my body. If this feels like too much for your arm, you can bring the hand to the rib cage instead. So I'm stretching the right side of my body, taking a breath in and coming back to center. Lifting the left arm up and over, or just sliding it up the rib cage. That right arm is nice and loose. Big breath in. You've got it, Paula. Beautiful. And we're coming back. We're going to flow a little bit. Breathing in, stretching over to the side, breathing out, and moving at your own pace. Doing a couple more side bends with me, if you so desire. All right, and that's it. I'm just going to swing my arms for a moment, loosening up my arms, getting things moving, getting things flowing. All right, and then I'm going to take my hands to my lower back and just massage my lower back for a moment. And I'm going to undo a little bit of that rounded posture that develops over time, just as being a human being on the planet Earth. And I'm going to lift up my heart and squeeze my elbows together. So I'm arching my back, but just a little bit. And I might lift my chin if that felt okay. I'm taking a big breath in and then releasing out of that and coming back down to sit. Coming back down to sit. And taking a moment to try a couple seated twists. So I'm just going to twist my body, my whole torso to the right, and I'll bring my arms in a way that will support that twist. And I'm taking a breath here, and as I exhale, I might twist a little bit deeper. And I'm coming back to center and switching sides. Big breath in. Exhaling, twisting to the left. See how that would feel for you to just twist the body to the left. Inhale, center. Exhale, right. One more time on each side. You've got it, Karen. Releasing to center. And last one. And then we're coming back to center. And before we dive back into more of this beautiful webinar presentation, I'll invite you to just rub the eyes for a moment, rub the hands for a moment, and just cup the palms over the eyes. And you could even take off your glasses if you want. Taking off your glasses and just rolling the eyes around for a moment, kind of resting the eyes. And sometimes with really crushing fatigue, as you've described it, crushing exhaustion, we do need to rest. So we have some classes you might enjoy when you're in that mode, such as a sound meditation or yoga nidra, and I'll talk more about those later. Blinking the eyes open and bringing the hands back down, and just noticing how that feels for you in your body, feeling a little more vitality perhaps, and getting ready to share a little bit more on the sleep portion of things. Thanks, guys.
Thank you so much. That was lovely.
Excellent. I'm happy to man the slides. Thank you so much. And
Okay.
Anne, that was phenomenal. I would love to have a movement in the middle of every webinar I provide, please. All right, so we're going to switch gears a little bit for the back half, and we're going to talk a bit more about sleep. There we go. So what is sleep disturbance, right? You hear this term sleep disturbance, but what does it actually mean? In general, there are 5 main types of sleep disorders that people can be diagnosed with or experience. They include insomnia, sleep apnea, hypersomnia, circadian rhythm disorders, and parasomnias. And I have insomnia highlighted here because that's the one we're really going to focus on today. The main reason for that is that a lot of times when people are talking about sleep disturbance, I'm having difficulty sleeping, they're talking about symptoms consistent with insomnia. Those include being unable to fall asleep, being unable to stay asleep, or waking up earlier than you want to in the morning. Just to provide a little bit more background, sleep apnea is it's a sleep-related breathing disorder where you stop breathing during the night, during your sleep episode, repeatedly throughout the course of the night. Hypersomnia is related to being unable to stay awake. Circadian rhythm disorders is when your body's natural sleep cycle and the world, our social rhythms, don't map onto each other. So your body wants to be awake at the times when your life don't really need you to be awake or doesn't really need you to be awake. Your body wants you to be asleep at times when your life doesn't really allow you to be asleep. So it's not that you can't sleep, it's that your body wants to sleep at a time that doesn't match onto your life. And then parasomnias include things that are really just unusual behaviors during sleep. So things like sleep talking, sleep eating, night terrors, things along those lines. But again, today we're really going to focus on insomnia. So as I mentioned, the main symptoms of insomnia are difficulty falling asleep, difficulty staying asleep, or waking up earlier in the morning than you want to. And two other really important components of insomnia disorder. So in order to be diagnosed as a diagnosable condition, it also needs to be bothersome and interfere with your life. One question that we get all the time is, well, how much should I be sleeping anyway? Right? Like, it used to be that you should get 8 hours of sleep a night. Everybody needs 8 hours of sleep a night. That is the holy grail of sleep. You better get your 8 hours or else you're doing something wrong. And over the not so distant past, I think more light has been shed on the fact that that's not really the right answer for everybody, because different bodies, different people need different amounts of sleep. You hear about those people out there who sleep 4 hours a night and are totally refreshed and up and ready to go. They exist. It is an actual thing. The number of people who actually experience that truthfully is a lot smaller than the number of people who think they experience that truthfully, but it does exist. So what we know, this is from the American Academy of Sleep Medicine, for adults age 18 years or older, the recommended amount of sleep is at minimum 7 hours of sleep per night for most people. Most people, it's about 7 to 9 hours of sleep. However, there are people for whom as little as 6 might be enough, and there are people for whom up to 10 may be required. But the sweet spot for most people seems to be 7 to 9 hours. And kind of mirroring what was shared about cancer-related fatigue, we're going to go through some of the same questions with sleep disturbance. So how common is sleep disturbance? When does it happen? And how long does it last? The answers are really the same. So it's extraordinarily common. It's often listed as the second, or at least one of the top 5 number or highest concerning and highest or most common side effects of cancer and its treatment. And it can occur across the cancer continuum. So that means it can start before diagnosis, at diagnosis, during treatment, when treatment ends, long-term survivorship. It can show up anywhere along that continuum. It also occurs across age, sex, cancer types, and different treatments. So it's not that only certain people experience sleep disturbance. There's some research showing that it may be a little bit more common among some populations than others. There's some research showing that particularly among breast and gynecologic cancer survivors, and I think lung cancer tends to show up a little bit more frequently. But whether that's actually the case, or if that's a function of there are more breast cancer survivors who have been participants in research because there have been more studies that have been done with breast cancer survivors, that's not entirely clear. So really what I would say is that it's more ubiquitous. It occurs really across cancer types. And what we know is that it can last for years. So unlike things like nausea or hair loss that tend to improve when treatment ends, sleep disturbance, not for everybody, but for some people, can last for years and years and years following termination of treatment. There's a study that came out, I think about 3 years ago, that looked at survivors 9 years post-diagnosis, and they found that 50% were reporting difficulty sleeping. So it can stick around. Well, why does it happen? Unfortunately, we don't really know this one for sure either. There are some theorized contributors, and some of these have some evidence behind them as well. including the cancer itself, psychological factors like depression and anxiety. Somebody mentioned earlier that depression and cancer-related fatigue can kind of be related to each other and look similar to each other in many ways. Depression and sleep disturbance, anxiety and sleep disturbance can be related to each other. Pain is a big one. It's hard to sleep when you're hurting. So pain and sleep disturbance are often related to each other. Medications are one thing that can be impactful. In certain types of cancer, it's very common to be put on corticosteroids. Steroids make it hard to sleep. So that's one thing. Some people may take opiates. Opiates can impact your sleep. So some of the medications that are taken for cancer and its side effects can directly impact sleep. The treatments as well can impact sleep. And then in certain cancers that are hormone related, people may experience medically induced menopause or andropause, which can lead to things like hot flashes and night sweats, which also can have a strong impact on sleep disturbance. And what exactly does it look like when it shows up in people's lives? So what we know from the literature is that having more disturbed sleep, having worse sleep is related to worse quality of life, more fatigue, more depression and anxiety, more of those symptoms like night sweats and hot flashes, more what's called cancer-related cognitive impairment. This used to be called chemo brain, and then people realized it happens outside of chemo also. So now it's been rebranded as CRCI or CRCD, cancer-related cognitive, not disorder, dysfunction, excuse me. And then there has been some link between sleep disturbance and mortality. I will say this same link shows up outside of cancer. So this is not unique to cancer, but what we see is that people who sleep a really, really, really small amount, so like less than 6 hours a night, and people who sleep a lot, so I think it was more than 9 hours per night, both of those populations, both of those groups tend to have higher rates of mortality than those who sleep more in that sweet spot of 7 to 9 hours per night. And that's been found both in cancer and in the general population. And one thing I also like to throw in here is that it's not just the survivors. So we see that for sleep disturbance in particular, this is one of the symptoms that shows up for survivors, but it also shows up for loved ones of survivors, those who may be providing unpaid care for somebody who has a history of cancer. So those kind of alphabet soup at the bottom there, that PSQI, that stands for the Pittsburgh Sleep Quality Index. That's a leading questionnaire that a lot of scientists and providers will use to look at sleep disturbance. Higher is worse. And what you see there on the left side, it's showing the percentage of people who answered that questionnaire who scored in the range of expressing or showing that they had sleep disturbance. And you can see it's a little bit higher than 50% for patients, but it's around 45% for caregivers. The GSDS is the general symptom distress scale, I want to say. That has a measure about, or an item, assessing sleep as well. And you can see the rates were a little bit lower. It doesn't assess sleep with quite as much nuance as the PSQI. So I think that's why it's a little bit lower. But you can see that, again, we're seeing really high rates of sleep disturbance. And then that TST score stands for your total sleep time. So the amount of sleep you're getting on an average night. And when we categorize people as having basically enough sleep or not enough sleep, you're seeing that it's really close in terms of about half of survivors and caregivers showing that they weren't getting enough sleep on a regular basis. So I do like to throw this out there because I think this is something that gets even less attention than sleep among cancer survivors, which already doesn't get enough attention. All right, so setting the stage, kind of getting us all on the same page in terms of what is this, how common is this? But I have no doubt I am preaching to the choir. You all know exactly what sleep disturbance in the context of cancer looks like. So let's switch gears and talk a little bit about what we can do about it. And I'm going to crowdsource our answer to begin again. So we're going to have another Slido poll. We didn't share this at the beginning, but I will share it now. We're going to delete these polls at the end of the presentation. So anything you put in will not be stored long-term on this website. And I actually just participated yesterday in a webinar that was hosted by the government, and they actually used Slido as part of that webinar, which made me feel a whole lot better about it. But if you'd like to go here, it's the same code that you had for the first time, but it should bring up a new questionnaire now. So I'm going to switch over so we can start looking at it. And the information about joining is on this slide as well here. And we're answering, excuse me, we're answering the question, what are some things you've done to help your sleep? I see no naps, shorter naps, reading, exercise, eat healthy, new mattress. The Calm app, excellent. Another mattress comment, podcasts, walking, beautiful. You'll notice everything is the same size, which means everything's been mentioned once. So we've got what I'm gathering is that you're all doing a lot of different things to try and improve your sleep. Melatonin, one of them got bigger. A recliner to reduce pain. I like that. Listening to music, wearing an eye mask. We're going to get to some of these later. Melatonin continues to be a popular one. I'm going to give it one more minute. Take a sip of my gigantic mug of tea. Magnesium. We have another one that's getting some multiple responses. Make room dark. Daily walking, smart with walking. Excellent. All right. So again, I think the take-home message here is that people who are here today, and I think this is true of individuals who experience sleep disturbance everywhere, do a lot. We really try really hard to chase down sleep and capture this elusive thing and really try and chase it down and see if we can catch sleep. So we're going to talk a little bit about things you can do to improve your sleep. I'm going to bring us back to the same booklet that Dr. Muench brought up before. This is a, I guess, handbook, for lack of a better word, from the National Comprehensive Cancer Network. It is designed for patients and their family members. NCCN has publications designed for providers and publications designed for patients. This is the one designed for patients. And this one talks about different treatments for sleep problems. So it includes sleep hygiene, devices. Those are really used for people who have sleep apnea, that sleep-related breathing disorder I mentioned at the beginning. Cognitive behavioral therapy, we've already talked about it. We're going to talk about it some more. Some medications for insomnia, and then medication for restless leg syndrome. So that's a different type of disorder that some people might experience. It can be targeted by medications or by diet. And the ones that are boxed in red here are the ones I'm going to focus on today. So starting with sleep hygiene. Sleep hygiene is, the way I think about it, these are behaviors that have the potential to get in the way of a good night's sleep. But in and of themselves, they are unlikely to lead to good sleep tonight. However, by kind of not listening to sleep hygiene recommendations, it has the potential to interfere with you having good sleep. So sleep hygiene includes things like going to bed and waking up at the same time every day, even on weekends, trying to have more consistency to your sleep schedule. This can help your brain and your body start to get used to a particular schedule, and your brain and your body will start understanding, oh, it's bedtime. It's time for me to feel sleepy now. Oh, it's wake up time. It's time for me to feel awake now. So that consistency can help. And I ended up cutting it out of this picture because I didn't want it made the picture too small, but this is actually taken from NIH, these recommendations. Another sleep hygiene strategy is to find ways to relax before bedtime each night. I don't know about you, but when I'm really wound up and really like energized and activated, it is extraordinarily hard for me to fall asleep. So while you cannot relax yourself to sleep, you can't make sleep happen by being relaxed. Not being relaxed can get in the way of sleep. So relaxing can help make it more amenable for sleep to show up. Avoiding distractions like cell phones, computers, televisions in your bedroom. This is such a hot button issue because nobody wants to take their cell phone or television or maybe computer out of their bedroom. I do the same thing. I do not want to take my cell phone out of my bedroom. It is like an appendage on my body. What I will say is that those distractions, again, can get in the way of sleep. So best case scenario, you would not have anything like that distracting in your room. If you are somebody who's like, that's real sweet, I am not going to do that. That is not going to work for my lifestyle. We understand that this is not going to work for everybody's lifestyle, but see if you can use them in a way that doesn't interfere as much with your sleep. You're not falling asleep to the television on, for example, or if you're watching television, you are in a television position. And then when it's time to go to bed, you shift your position into a sleeping position to help differentiate these activities from sleep and sleep time. Other things you can do, avoid eating large meals or caffeine or alcohol late in the day. Alcohol is an interesting one because a lot of people say it helps them feel sleepy, and it does. Alcohol has a sedating effect. However, what we know is that sleep onset that's achieved comes at the cost of the second half of the night. Alcohol can make it so your sleep is less restorative and less restful later on in the night. So while it might help you fall asleep initially, the quality of sleep that most people get isn't as good. So we don't generally recommend it for supporting sleep. Exercising at regular times each day can be helpful, not too close to bedtime. Exercise can make your body temperature get hotter because of all of the activity, and your body temperature getting cooler is one of the things that naturally happens over the course of the day and helps your body know when it's time to go to sleep. So if you raise your temperature, it's going to take longer for it to come back down to the place where it's cueing your body that it's time for sleep. So exercise can be really helpful in terms of promoting sleep and promoting consistency. You just don't want to do it too close to bedtime. And then, as was mentioned earlier, avoiding long naps. So anything more than 30 minutes in the late afternoon or evening can be problematic. That nappuccino is one of my favorite things. I learned about it from Dr. Muench. And the kind of thinking behind that is that it takes some time for the caffeine to start working in your body. It takes about 20 minutes, usually, sometimes up to 30, for your body to register that caffeine has entered the system. So if you drink that coffee, lie down and nap for 20 minutes, you're waking up just in time for that caffeine to come online and promote that alertness. So you use that window when it's kind of getting into your system as your sleep window, and it can be really effective. This was a strategy that actually came out of, I think it came out of the military. Is that correct? Dr. Muench, do you remember?
Sorry. Yes, it did. It was, I'm trying to remember who exactly, but yes, it came out of the military. I think work with pilots was where it was coming from. Yeah.
Excellent. All right. A little bit more about sleep hygiene. So we talked earlier about seeking out bright light during the day. Light is one of the number one things that helps your brain know when it's time to be awake and when it's time to be asleep. So if you can get exposure to light during the day, it helps your brain understand, oh, it's daytime. It's time for me to be awake now. The flip side of that is avoiding bright light at night and turning off your devices, like your phones that emanate blue light, turning them off closer to bedtime, or at least shifting the color so it's less of a bright color closer to bedtime can help, because otherwise that light gets into your brain and it tells your brain it's time to be awake. So again, that can interfere with sleep. Similarly, sleeping in a dark, quiet, comfortable place, comfort makes it easier for sleep to come to you. One of the things that is a strategy that people sometimes use, we hear a lot from people who have difficulty sleeping that they get into bed, they lie down, they put their head on the pillow, and then their brain reminds them of absolutely everything that has ever gone wrong in their lives and ever could go wrong in the world until the end of time, right? And we all have these worries that live in our minds. And oftentimes, for people who are very busy, who may have a lot of responsibilities, who may be doing a lot during the day, when you lie down in bed at night is the first time that all of those other distractions are peeled away, and your brain all of a sudden has an opportunity to think about all of those things that are living in there and are taking up space. And boy, oh boy, does your brain love taking advantage of that opportunity. But thinking about all of those worrying things can get you activated and can get you anxious. And anxiety and activation make it harder to fall asleep. So one strategy that psychologists sometimes use that's recommended is to schedule a time that's not your bedtime, and it's not too close to your bedtime, to actively think about your worries. Say, okay, brain, I understand we need to think about these things. We need to have time to focus on these things, but we're going to do it on my schedule. You don't get to decide when we do this. I get to decide when we do this. And you set aside a time that is limited with an alarm, Maybe you link it to an activity. I've worked with people in the past who have linked this to doing the dishes. So while they do the dishes, they actively think about all of the worries that they have. And then when the dishes are clean, they're done with their worry time for the day, and they will do it again the next day when they're washing dishes again. So something that's time limited. It can be helpful because then at night when you get into bed and those worries start creeping in, you can say, hey, now brain, you're going to get your chance. You will have time to think about this, but now is not that time. And sometimes just giving an opportunity for it can be helpful in terms of taking away some of its volume and some of its power late at night. And then the last thing I'm going to talk about is not looking at the clock at night. So people raise questions about this all the time. I'll never forget, I was in a lecture at one point and I heard somebody say, what's the first thing that you do? You know, you wake up, you open your eyes, you look at the clock, you see it's 3 o'clock in the morning. What's the very first thing you do? Math. It's the first thing that happens. You wake up, you see 3 o'clock. Okay, so I fell asleep at 10. That means I've been asleep for 5 hours and I have to get up at 7. So if I fall back to sleep right away, I can get at least, 7 hours of sleep tonight or 8 hours of sleep tonight. Math doesn't help sleep come. Math chases sleep away, So best case scenario, it's neutral. You look at the clock, you realize, oh, I already got a lot of sleep, or, oh, I have a lot of sleep left to get, and it doesn't interfere with falling asleep. Best case scenario, it's neutral. That's very rare. More often than not, it makes it harder to fall back to sleep because you start doing that mental math, you start getting worked up, you start getting anxious that you're not going to get enough sleep, and it makes it harder to fall asleep. It really doesn't matter if you wake up 5 hours before your alarm or 5 minutes before your alarm. What matters is it before your alarm or after your alarm? So what I'll often recommend to people is set an alarm and cover it up and don't look at it again until the morning, because that math that is going to happen is only going to work against you. Now, what I'll say with regard to these sleep hygiene tips, I think about them a lot like dental hygiene. These are the things that you can do to try and help sleep or help promote sleep, right? So if you brush your teeth and floss your teeth, it makes it less likely that you're going to get cavities. However, if you already have a cavity, you can brush and floss to your heart's content. It is not going to make that cavity go away. Sleep hygiene is similar. These are things you can do to make it easier for sleep to happen, to make it less likely that you develop something like insomnia. However, if you have insomnia, if you have clinical difficulty sleeping, this sleep hygiene is not going to be enough, most likely, to actually get rid of or treat that diagnosable condition. I'm going to talk for about half a second about sleep aids. Again, like Dr. Muench, I'm a licensed clinical psychologist. I do not prescribe medication as part of my practice. I am not trained to do so, so I cannot make specific recommendations about medications. What I can say is we know from the literature that sleep aids are among the most frequently prescribed psychotropic medications, both in cancer and in the general population. There is more research needed specifically in cancer, however. So this is something, if you are interested in taking something like an Ambien or like a medication to help your sleep, speak with your physician to see if this would be appropriate for you in your specific case. What I'm going to talk a little bit more is about behavioral strategies, so non-medication strategies for improving sleep. And the gold standard is CBTI, or cognitive behavioral therapy for insomnia. This is something that was brought up briefly earlier. So CBTI involves a number of different components, including changing your sleep schedule, changing what you do when you can't sleep at night, addressing your thoughts about sleep, some education about sleep. It includes those sleep hygiene strategies we talked about, but that's not all it has. It also incorporates relaxation strategies because, again, not being relaxed can interfere with sleep. And for somebody who's taking a sleep aid and wants to stop taking it, it can include a taper off of that medication. In terms of what CBTI looks like, the structure is very similar to other types of CBT that was mentioned earlier. It usually involves meeting once a week for an interactive session with a therapist, though it can be less frequent depending upon where you're going and what resources are available. There are also online self-delivered or self-managed programs that are available that can be helpful. Research shows that they help more than nothing, they don't tend to have effects that are quite as helpful as working one-on-one with a therapist. And some examples include Sleepio, Shut-Eye, and CBTI Coach. Of these, I'm not specifically recommending any. I just know that these are out there and have strong evidence base behind them. I believe CBTI Coach is the only one that's free. The others do have a subscription fee. Typically, you'll work through 4 to 8 sessions or modules. And what I will say is, in terms of falling asleep on any individual given night, medications work faster, CBTI works longer. CBTI is teaching you how to adjust your relationship with sleep for the long term, whereas medication is helping the chemicals in your brain adjust so you can fall asleep tonight. I'm going to go through this very quickly because I realize we're closer to the end of time than I anticipated. There are some other strategies. Again, these are all non-pharmacological. One is mindfulness-based treatments. Dr. Muench mentioned mindfulness very briefly with fatigue. There's also some evidence supporting mindfulness-based treatments for insomnia, including this here is a specific protocol that people can work through. And there's also some evidence that bright light might help sleep, although this is in earlier phases of research than the research for bright light and fatigue. But these would be the exact same devices that you would see that we talked about earlier with regard to their relationship with fatigue. And I'm going to invite Dr. Muench to jump back in and speak a little bit about the relationship between cancer-related fatigue and insomnia.
Yeah, so I think I said this earlier, but the prior literature had suggested that cancer-related fatigue and insomnia were 2 distinct entities, which may be true. I often get on my cancer-related fatigue soapbox, and I try not to conflate the two because there's some suspicion that they're different. However, it doesn't mean that the treatments for that we use for insomnia, like CBTI, can't be helpful. And there's some reasons behind this. So if you want to click. So what contributes to these things? So both myself and Dr. Fox have said that there's similar, we think, factors like physiological factors, which can include pain, insomnia, and or anemia, as well as chronobiological factors. So this is your circadian rhythm. This is your clock inside. So there's some research to suggest that during treatment, you lose your stable sleep-wake pattern. Also psychological factors like depression and or anxiety, as well as cancer type and stage, and the iatrogenic effects of treatments. What this means is treatment itself can lead to cancer-related fatigue and or insomnia. And then finally, late diagnosis and treatment. So sometimes there can be differences by race and ethnicity when you're diagnosed and when you're treated, which can lead to increased risk for fatigue and insomnia. So did you want me, I'll do this one. So there is an interrelationship between CRF and sleep disturbance. So again, I said this already a couple times, but cancer-related fatigue is posited to be unaffected by rest or sleep. Again, this is not evidence-based. There have been relationships found between fatigue and insomnia, and CBTI does seem to improve outcomes in both sleep and cancer-related fatigue. And so it's also been suggested that cancer-related fatigue may be related to sleep fragmentation, shallow sleep, and or short sleep duration versus insomnia, and that these things may be related. So that's all to say. We did a study and are doing a study on insomnia and fatigue. This is in breast cancer. And we found that cognitive behavioral therapy, especially at a higher treatment dose, meaning a higher number of sessions, so typically CBT for insomnia is around 8 sessions, we were testing it at 10 and 12, can improve not only sleep, as you can see here as defined by our measure, the insomnia severity index, but also fatigue. And we measured this using a fatigue measure called the FACIT. So both things improved. Just a caveat, the FACIT is reverse measured, which can be a little confusing, but higher scores indicate less fatigue, with scores around 30 indicating some severe fatigue in our patients were better by the 3-month follow-up mark. So what you see here is improvements on both, which means that there may be hope and that this behavioral intervention may in fact help cancer-related fatigue, which is awesome. TBD though, don't want to get too excited. We're still testing it, but fingers crossed, our pilot data was really, really promising. So thank you.
All right. I think we're actually not going to do another meditation, Anne, is that correct?
Yeah, we were going to share a little bit about the resources that are available via our YouTube, and then also talk about when those can be attended live. But
Perfect. I just want to quickly acknowledge before I fully hand it over, Dr. Lisa Wu is a professor actually at Aarhus University now in Denmark, and she was instrumental in helping to develop these slides. So I do just want to make sure that we acknowledge her contribution quickly. And then Anne, I am happy to hand it back to you.
Okay, well, first let's go over some of the questions that have come up in the chat. And after we go through these questions and I tell you a little bit about the resources that we do have via our YouTube playlists and live classes that you can take, we'll then stop the recording and you guys can stick around if you need to stick around, maybe for like 5 more minutes, if there are any other questions that you wanted to ask on camera. So getting a lot of nice things coming in on the chat, but we had some questions about how do you know if you're getting enough sleep, and how can you increase the amount of deep sleep? I thought those were really interesting questions from Bill. Do either one of you have anything you might speak to? How do you know if you're getting enough sleep, and how can you increase the amount of deep sleep?
So I think in terms of how to know you're getting enough sleep, what I have heard people say is really kind of reflecting on how you feel when you wake up. So if you need an alarm to wake up every morning and you are absolutely positively dragging out of bed and you feel like garbage when you wake up, you're probably not getting enough sleep. If you're waking up without an alarm, that indicates that your body may well be ready to be done sleeping. If you wake up feeling refreshed, if you find that you're able to live your life and engage in activities the way you want to with the amount of sleep you're getting, you're probably getting enough sleep. I will say that there's something called sleep inertia, which is a common part of normal healthy sleep. That's that difficult feeling we all feel in the morning when we first get out of bed, that we're just kind of slow to get moving. So you can be a little sluggish in the first 10 minutes or so after you wake up, but still feel reasonably refreshed and rested. And that can be part of normal healthy sleep. But if you're one of those people setting multiple alarms, snoozing repeatedly, and just really dragging, that probably suggests that you're not getting what your body needs.
Thanks so much for answering that. Someone here in our group said they have sleep issues due to depression and they're being given trazodone. What do you think of that?
So trazodone is something that it's frequently used for both depression and sleep. Again, I'm not trained to comment on pharmacology. However, sleep disturbance, much like fatigue, can be a symptom of depression. So all these symptoms tend to really go hand in hand. And what you do sometimes see for somebody often see for somebody whose sleep disturbance is secondary to depression, that as the depression improves, sleep may also improve. Now, it may be that some of the behaviors around sleep that somebody has started using during a time when they're feeling really depressed might lead their sleep to still be problematic even after that depression gets better. That can sometimes happen. But trazodone, again, it's a very commonly used medication. I would say if it's working the way you want it to, continue working with your provider. That's great. I'm pleased to hear it's working as you want. If it's not working the way you want it to, talk to your provider to see if there might be something else that would be appropriate for you.
Thanks so much. Are there any long-term issues associated with melatonin use? For example, one of our friends here uses 10 milligrams a night.
That's a really hot button issue. So melatonin, and Dr. Muench, I'm sure you want to jump in on this too. Melatonin is one of the most commonly used supplements. Many people do not use it the way that the evidence supports it. So this is not to bash anybody who's using melatonin. If you're using melatonin and you're finding it works for you, nobody's looking down on this. What I will say though is melatonin is not designed to be a sleep aid. So the way something like an Ambien or a trazodone or something like that is designed to put you to sleep tonight, melatonin is not designed to make you feel sleepy. Many people do anecdotally find it has a sedating effect. So for a lot of people, it does help them feel sleepier, That's not what it's designed to do. Our brains naturally release melatonin a couple of hours before our typical sleep time. And that's a way that our brain is telling our body, hey, it's nighttime and it's time to get ready for sleep. So the melatonin is really designed to help regulate that circadian rhythm, that rhythm that's telling your body it's time to be awake, it's time to be asleep. When you take a melatonin supplement, some people will take it for circadian rhythm issues, a couple hours before they're intending to go to bed. Most of the research that's been done has looked at therapeutic doses between 1 milligram and 3 milligrams, which is much smaller than what most people use when they're buying it over the counter. And again, a lot of people, when they're buying it over the counter, they'll take it at bedtime to try and fall asleep right away. I am not aware of any negative outcomes associated with long-term melatonin use. It doesn't mean it isn't out there. It just means that either it hasn't been studied or it has been studied and I just haven't come across it, but I am not aware of it. I'm really not aware of many negative outcomes related to melatonin use at all. So if you're using it and you're finding it's helping, I'm not aware of negative things that happen as a result of that. One of the things that people need to be mindful of is that melatonin is considered a supplement, which means it's not regulated by the FDA, which means nobody is verifying what is in the pill that is being purchased over the counter. This is true for all supplements, not just melatonin. So it's really hard to know exactly what's happening, or if somebody is buying something that is just going to get flushed right out of their system without having a really strong mechanistic effect. But in terms of kind of the ultimate question around it, I am not aware of negative long-term things. Dr. Muench, I'm sure you want to jump in on this because this is always such a hot button issue.
Yeah. So what I'll add is it is a hormone, and so it does impact I think it's progesterone. And so oftentimes when I have, an adolescent patient or a woman going through menopause, or my patients who have been diagnosed with breast cancer and they're taking melatonin at higher doses, I do caution just that it can have an effect on your hormonal system. Now, again, as Dr. Fox said, these are over the counter. We don't know how much melatonin is actually in them and what other ingredients have been put in them. But what I will say is, again, melatonin is a hormone. So I always provide that education and just be aware that we just need to be cautious with it in certain populations.
Absolutely. Thank you. And the other thing that reminded me of is there are certain pretty common medications that can suppress the natural release of melatonin. So beta blockers, for example, are one that can make it so your brain doesn't release melatonin as much as it otherwise maybe would have. So that is something where it might be appropriate to take a supplement. You would just want to talk to your doctor about it before changing anything.
All right, guys. Thank you so much for attending, everyone who stuck around for this, for coming and spending this time with us today. And thank you so much to the IWMF staff for helping us out today. If you loved learning from these two today, as I did, will you please let us know in our follow-up poll, which I'll be sending out along with the recording. If you are interested in combating fatigue with movement, we have classes for that. One of them is cardio flow class. That's meeting tomorrow at 2 p.m. Eastern Standard Time. And you can reach out to me directly to get on that mailing list if you're not already. And then for sleep, for creating that sleep-like atmosphere, we also have some meditations and some practices that are available on our YouTube. So I just popped all those links into the into the chat feature for you here, and I'll also put it into the YouTube description of this particular recording. One thing in particular I want to underline, specifically Yoga Nidra. The word Nidra means sleep, and actually, although the goal of the practice is not to sleep, it's to hover between wake and sleep. There is research that supports use of Yoga Nidra to decrease stress levels and improve sleep quality. And that was a research study that was done in 2022 that was published in Current Psychology. And it was just a very short dose of that meditation that could positively influence stress, sleep, and well-being. So that is the practice that I have trained in, and I love sharing. And it's 30 minutes of guided relaxation, visualization, and breath work. So I hope that you can check that out. And maybe you, Dr. Fox, and you, Dr. Muench, could join us for a yoga nidra sometime and see how you like it, and pass that along to anybody you think it could be helpful for.
Absolutely.
All right, thanks so much. We're going to stop the recording now and see you when we see you.